So my parotid region is the region that is around the ear. Forgive me, I won't follow the slide per se, but I'll just use it for pictures here and there. So the parotid region is the region around the ear, right? Which is bounded anteriorly by the anterior border of the masseter muscle, which we said inserts onto the lateral surface of the ramus of the mandible. Then superiorly, it's bounded by the zygomatic arc. Posteriorly, it's bounded by the mastoid process. Then inferiorly, it's bounded by an imaginary line that joins the mastoid to the angle of the mandible in that corner there. So the inferior boundary of the parotid region is an imaginary line that will join the mastoid process to the angle of the mandible. Right? And what I find the principal structure for that region is the parotid gland, hence parotid region. Within the parotid gland, I find a nerve, I find an artery, and I find a vein. These are things that are passing innocently through the parotid gland. For example, I have the facial nerve, which whilst in the parotid gland will give me the 5 branches going to the muscles of mastication. Facial nerve on its own is not innervating the gland, but it's passing through the gland. The artery that I have in this gland is the external carotid artery, right? Then the vein that I have, remember I said external carotid divides into maxillary artery and superficial temporal. The vein that I have within our parotid is what we call the retromandibular vein. Retromandibular vein is formed from the corresponding veins from the termination of the artery, meaning maxillary vein and superficial temporal vein. Right. So to build your story, facial nerve, when you do your neuro, to exit the brainstem at the pontomedullary junction, find its way through the cerebellopontine angle, then travel with vestibulocochlear nerve in your internal acoustic meatus. Then from internal acoustic meatus, it goes into the facial canal on the medial wall of the middle ear, then goes into the vertical part of the facial canal on the posterior wall of the middle ear, then exit the facial canal via what we call the stylo-mastoid foramen, which is a foramen between the styloid and the mastoid process in that region. Right. After exiting the ear in that region, it then enters the parotid gland. Right. So parotid, I think I talked about that yesterday, that otic means ear, para means around. So this is a salivary gland that lies around the ear. It's the largest salivary gland. So I have 3 major salivary glands: parotid, submandibular, then sublingual. Parotid is the largest, but funny enough, it doesn't produce the most saliva. Okay? The most saliva actually comes from the submandibular salivary gland. So this here is my parotid. When AIDS started in the I don't want to like the years, but When AIDS started, one of the presenting features for those people was a swollen parotid. And before the advent of ARVs and stuff. So you guys haven't done just excuse me. You guys haven't done the other systems. Your parotid, histologically, it resembles what we call the pancreas. I'm sure everyone knows about the pancreas, produces insulin, glucagon, pancreatic polypeptide, plus enzymes for digestion. So the parotid and the pancreas resemble each other histologically, such that if you put a picture of the pancreas to that of the parotid side by side, if you are not clever enough, or if you can't really tell histological structures, you can't differentiate them. So I used to teach people saying that there are 4 differences. 2 of the differences are unique to the parotid. 2 of them are unique to the pancreas. So when I look at salivary glands can either be serous. If you're a serous gland, you produce a serous fluid, or a serous saliva in this case. A serous fluid is a watery fluid rich in protein. And the protein in this case will be, what do you call this? Enzymes. Remember, in saliva there's salivary amylase and salivary lipase. That's where digestion starts in the oral cavity. Then the other 2, which are submandibular and sublingual, these are mixed salivary glands. They have a serous part, then they have a mucus part. A mucus secretion is a sticky, thick secretion which is rich in mucins. Mucus is what you call madziwa, right? So submandibular is a mixed salivary gland, but it's rich. It's mostly serous, but there is a bit of mucus there. Sublingual, it's a mixed gland as well, but it's mostly mucus. And if you go to your nerve and muscle in physiology, you'd remember that the salivary glands were one of the few places where sympathetic and parasympathetic will not necessarily be opposing each other, but will be acting synergistically, where they both promote secretion of saliva. The only difference is the type of saliva that you produce. For example, the parasympathetic outflow will favor secretion of a watery, copious saliva, meaning I want serous secretion. Then sympathetic secretion will favor release of what we call a sticky saliva. And if I fast forward a bit before we even go to this parotid beds, it's a salivary gland. I'll go back to the differences. Pancreas is an endocrine gland. Others would love to call it exocrine because it also produces hormone, not enzymes, I mean. Parotid is exocrine. Exocrine glands release whatever they release via ducts. Endocrine glands release whatever they release straight into the blood, meaning I need capillaries within an endocrine gland. Right. So one of the differences in between parotid and pancreas is that within the parotid, I have what I call myoepithelial cells. Myo means muscle. Epithelial means lining. So these are lining cells that can contract. And these are unique to the parotid, and in the pancreas, they are not there. Why? Because once I produce saliva, to move the saliva, I need cells that will contract. And those cells that are going to contract are the myoepithelial cells. For pancreas, if you do your GIT, physiology, whatever, yada, yada, you'll see hormones that will help release pancreatic components, things like secretin, CCK, and so forth. Right. So that duct system of the parotid, if you go to the histology, you start with there's in intralobular striated ducts, then interlobular, then the parotid duct itself, also known as Stenson's duct. So I want you to do this after you exit the meeting when we are done. Take a mirror, find your second molar tooth, then look opposite the crown of the second molar tooth. You find a whitish region or a whitish papilla there. That is where the parotid duct opens. So it opens opposite the crown of the upper second molar tooth. It's very easy. Maybe if you look at a friend, just say, open your mouth, then you look. Right. Okay. Then there's what you call the parotid bed. Some of these things, I'm not so sure if they're important unless you'd want to be a maxillofacial or something. Right. We find our parotid gland in something called a pyramidal fossa, which lies behind the ramus of the mandible. And that's what we call the parotid bed, where we have that parotid. So would you want me to tell you the boundaries of this parotid bed, or you don't need it? Guys?
Just go ahead.
I know you forget this one, but it's fine. So posteriorly for the parotid bed, I have the mastoid process. Anteriorly, I have this ramus of the mandible. So the posterior border of the ramus of the mandible here, that's the anterior relation of the parotid bed. Then posteriorly, I have the mastoid process. Then medially, I have the styloid process. Right. Then superiorly, I have the external auditory meatus, which is part of the ear. Right. And if you want to be fancy in life, this parotid bed is lined by muscles. Here on the ramus of the mandible, I have the masseter. I also have the medial pterygoid muscle. On the mastoid process, I have sternocleidomastoid. That's where it inserts. It's the muscle in the neck. I think we can see it here. It's cut. And I also have the origin of the posterior belly of the digastric muscle here. Then on your styloid process, there are a lot of muscles there like styloglossus, stylopharyngeus, stylohyoid. Right. Do you think you can palpate your parotid gland?
No.
Why not? You're correct. Why not?
I'm not so sure. but I think it is because it is inside the ramas.
No, it's not inside the ramas. Remember I said it's behind the ramas. So it's too soft to be palpated. Meaning in people who get mumps parotitis, which is infection of the parotid by a virus known as mumps virus, it gets hard and you can palpate it. Right. Then I know I talked about a parotid bed, but the parotid gland is not limited to the parotid bed. It's a soft structure, meaning it can extend beyond that parotid bed. It can even go beneath the zygomatic arc. It can even seep into the submandibular region lower down there. It can even seep into behind the ramus of the mandible. Right. Then does anyone remember a point that goes like, there is no deep fascia on the face? Does anyone remember that?
Yes.
But at the end of that statement, it should read except. So there's no deep fascia on the face except over the parotid and the masseter muscle. When you do neck, your neck has 3 layers of deep fascia, which are namely investing layer of deep cervical fascia, then pretracheal, then prevertebral. Investing layer is the fascia of twos. It encloses things in twos. It's going to enclose 2 salivary glands, which are submandibular and parotid, of which parotid is on the face. So that deep fascia will cover the masseter on its way to enclose the parotid. Meaning, yes, on the face, there is no deep fascia, but there's an exception over the parotid and the masseter where we find some deep fascia. Right. Then, remember I said the facial nerve lies within the parotid gland. And whilst in the parotid gland, it divides into its terminal branches, which we can best remember by saying to Zanzibar by motor car. Sure, most ladies will remember this one, Zanzibar. I think there are a lot of people who talk about holidays in Zanzibar nowadays. For the gentlemen, we can just say to Zimbabwe by motor car.
Sorry, I have a question.
Huh?
I'm saying I have a question.
Sure.
At some point, yes, at some point I saw a mnemonic that says please, but which the please was standing. Okay, please to Zanzibar by motor car. Yes, but the please was posterior auricular. So I'm not so sure if it should be involved.
So posterior auricular is it's given off before the nerve enters the parotid gland. It's actually given off whilst the nerve is in the facial canal, and it goes to innervate the posterior bellies of the occipitofrontalis. So yeah, it's still a branch of facial nerve, I agree, but it's not part of the terminal branches in the parotid.
Oh, okay. Thank you.
Okay. So 2 is temporal branch, mostly for occipitofrontalis and some of the muscles of the eye, like orbicularis oculi. I have zygomatic branch, I have buccal branch. Buccal branch is for vaccinator. I have marginal mandibular, then I have the cervical branch. Cervical means neck, meaning this cervical branch will innervate a muscle of facial expression that I find in the neck, which I call the platysma muscle. Right. This here is your posterior auricular here, though not labeled, but it's this one. Now going to the occipital bellies of occipital frontalis. Then I said retromandibular vein is formed by superficial temporal vein plus maxillary vein. And this retromandibular vein, it divides into an anterior division and a posterior division. Right. The posterior division of the retromandibular vein plus another vein known as posterior auricular vein. When they join, they form the external jugular vein, which we'll see in the superficial fascia of the neck. Then anterior division of retromandibular vein will join the facial vein and they form what we call the common facial vein. They do not form the internal jugular vein. They form the common facial vein. Internal jugular vein is a direct continuation of one of the sinuses of the brain known as the sigmoid sinus, the one that we say passes through jugular foramen. So internal jugular is coming directly from the brain, and it will get tributaries along the way, which include common facial vein. So common facial vein is anterior division of retromandibular vein plus the facial vein itself. Right. So I said there is facial nerve, there is retromandibular vein, then there is external carotid artery. Right. In terms of arrangement, the facial nerve is the most superficial, followed by retromandibular vein, then your external carotid is the deepest. Right. Did I say the parotid duct, also known as Stenson's duct, opens opposite the crown of the upper second molar tooth? For the bare minimum, that's enough. Right. If you want to be fancy, this parotid duct has 3 bends, meaning it's not straight. And if you want where it bends, we can talk about it. So overall, it's about 5 centimeters. That's our parotid duct there in green. Right. It's about 5 centimeters. And when it reaches the anterior border of the masseter muscle here, that's where it bends 90 degrees, the first bend. Right. Then it pierces a buccal pad of fat in your in your cheek. It pierces the buccal pad of fat, buccopharyngeal fascia, as well as the muscle there, which is baccinator. Right. That's the first bend, 90 degrees. Then after piercing those, the buccal mucosa, the baccinator, whatever, it bends again for the second bend. Right. And after bending there, it then bends medially again to form a third bend before it opens opposite the upper second molar tooth. So it does bend 3 times, but I haven't seen where it really helps. That's the parotid papilla that I was talking about. If you can do that to one of your friends or even on yourself, you can see a whitish papilla where parotid duct to open. Then the nerve supplied to the parotid gland. I talked about this yesterday, saying it's the otic ganglion. And this otic ganglion is fed by glossopharyngeal nerve or the glossopharyngeal nerve via the inferior salivatory nucleus in the medulla. Creates glossopharyngeal. Then glossopharyngeal gives us tympanic branch of glossopharyngeal, also known as Jacobson's nerve. Pierces the floor of the middle ear, goes and ramifies on the medial wall of the middle ear to form tympanic plexus. Then tympanic plexus would then form lesser petrosal nerve that pierces the anterior wall of the middle ear, gain access to the middle cranial fossa, pass through foramen ovale in the roof of the infratemporal fossa to gain access to infratemporal fossa, where it synapses on the otic ganglion. Then I said, after the ganglia, parasympathetic fibers in our head and neck, they will then travel with branches of the trigeminal. And in this case, within infratemporal fossa, there is V3. So they use a branch of V3, which is specifically auriculotemporal nerve. So auriculotemporal nerve then becomes the final pathway for the parasympathetic fibers that are going into the parotid gland. Sympathetic fibers for the head and neck, they follow the arteries. So you always have a sympathetic plexus around the major arteries. Right. Having said that, what's Frei's syndrome? What's Frei's syndrome? Guys, anyone ever heard of Frei's syndrome? It's a very interesting syndrome. What innervates the skin of the face?
Trigeminal.
So trigeminal except
Except the facial, the parotid region.
so except the skin that overlies the parotid. Eh? The skin that overlies the parotid is innervated by a nerve known as greater auricular nerve, which carries C2 and C3 fibers from the neck, particularly the cervical plexus. So Frei's syndrome is a very funny clinical scenario where there is a lesion of the auriculotemporal nerve. And basic neuroscience tells me that if the cell body, I don't know if you call it the soma, the pericardium, whatever, if that cell body is still intact, the stump that is the cell body will regrow. Do you know that? Let me draw. I have parotid. That one is auriculotemporal nerve. Then this is the skin overlying the parotid. The skin overlying the parotid is being innervated by greater auricular. Right. So the bad thing now is I cut my auriculotemporal nerve there. The cell body is here. So this part after the lesion will die because the cell body is not providing neurotrophic factors for it. This part will survive and regrow because the cell body is attached to it. But when it regrows, it doesn't mean it will regrow into the parotid all the time. It can decide to regrow and join that greater auricular nerve. So when I then see food, instead of salivating, I'll sweat excessively. Because the nerve for salivation is now connected to the nerve for the skin, which is for sweating. And it's quite evident in white people or those that you call yellow bones, because when they sweat, the sweating is so excessive that they swell and they become so red in the parotid region, and it's quite painful. It's called Frey's syndrome or auriculotemporal nerve syndrome. And mumps virus is not really a desirable thing. It causes infertility. So yes, it will attack the parotid, but it also attacks the testes and the epididymis, causing what we call epididymoitis, which leads to infertility in males. So mum is a type of virus, and it affects your parotid. Then you can get parotid fullness in HIV infection. I talked about the parotid swelling, and then you can have salivary stones within the parotid duct. Then we can have a lesion of the facial nerve within the parotid, and a lower motor neuron lesion is what we call Bell's palsy for facial nerve. Lower motor neuron means we have just affected the facial nerve anywhere outside the central nervous system. And what's the presentation of someone with Bell's palsy? Anyone know their appearance? The only way you can know is if you know what the nerve is doing. Right.
I think it's through the eyelids and salivating through the angle of the
Okay, so I know everything else will make sense, but please repeat what you said about the eyelid. Hello?
Oh, sorry, I was saying drooping of the eyelids.
The eyelids I have two eyelids. I have upper eyelid and I have lower eyelid. So which one?
It should be the upper.
No. Drooping of the upper eyelid, I see that in oculomotor nerve palsy, because levator palpebrae superioris is not working. I also see that in Horner's syndrome, which is a problem of sympathetic nervous system. Facial nerve. Facial nerve is for muscles of facial expression, and around the orbit, I have a muscle that encircles the orbit, which I call orbicularis oculi. That muscle functions to close the eye, the palpebra, the palpebral fissure, the space between the upper eyelid and the lower eyelid, where we say the palpebral fibers gently close, then, then the orbital fibers tightly close. So they get drooping of the lower eyelid, which is known as ectropion. unlike drooping of the upper eyelid, which we call ptosis. So they get ectropion. If the lower eyelid droops, tears will flow onto the face. We call that epiphora. They get loss of the nasolabial furrow. This fold here, it's normal. If it's absent, that person is sick. They also get sagging of the angle of the mouth on that side. They lose wrinkling of the forehead on that side. And if the lesion is happening in the parotid gland, they can still lacrimate. They can still produce tears. Unlike a lesion that happens before the geniculate ganglion, somewhere higher up, still a lower motor neuron lesion, but they affect lacrimation. That's a sign that tells you where the lesion is. If you look at lacrimation, tear production. Because facial nerve is also involved in tear production. That's parotid gland. Parotid region, I mean. Any questions on it? Guys? I remember when I started teaching. Yeah.
Oh, sorry. I wanted to ask about the salivating of at the angle of the parotid. I don't know if it's true or not. I read something like that at some point.
What do you mean?
Like, I mean, when they were talking of when you're just salivating by the angle of the mouth. I don't know how best I can explain it. Like, is it a disorder or it's caused by what? Maybe let me say what causes it.
As in salivating by the angle of the mouth.
Yes, that's what I mean.
It can still be Bell's palsy where there's drooping of the angle of the mouth and saliva just draws out.
Oh, okay.
Yeah. But there are other things that can also cause that. It's not only Bell's palsy.